Good morning, everybody. Thanks for joining us. With me today, we're going to have Don Moffett, Earl Jefferson, and Abiba Kindo to present the material that we have. We have a relatively few number of slides, so we're going to move through those, and then we'll go to a question and answer period. And as Megan said, if you could type your questions as we go through into the Q&A box, we'll be addressing those at the end. We have a lot of folks on the line today, so the only way we're going to be able to address questions is via the Q&A. The other thing I just wanted to let folks know before we get started is that this is intended to be a technical session for rehabilitation and pre-vocational services providers. We will have a recording available in a few days once we finish this presentation, and we're also working on a series of questions and answers that will be published, we're hoping, very, very shortly. So if we are unable to answer your question today, then we will certainly be reviewing those and making sure we can get you a response as quickly as possible. So, who's affected by these changes? What we're talking about today affects rehabilitation and site-based pre-vocational services. We're holding this webinar because we just received CMS approval on an update of our COVID-19 Appendix K. The changes we are discussing today will be retroactive to October 15th, 2020. And as a level set, just so everyone remembers, the Appendix K waives certain requirements and provides temporary flexibilities during an emergency. The OPWDD Appendix K currently runs through the end of March, but we're confident and we're working with CMS on an extension that will last past the end of the public health emergency. So the changes that we're talking about today will be in effect for many months to come, and we are hoping and anticipating that there will not be any further changes or need to amend the Appendix K. So, before we get into the meat of the presentation, there's two sets of flexibilities that I want to focus everyone in on. The first is our Appendix K provides certain flexibilities for all providers, and the list that you see on the chart in front of you are those provisions of the Appendix K that apply to all rehabilitation and pre-vocational services. So, all services, rehabilitation, pre-vocational services, can be provided via remote telehealth service delivery modalities. That continues for all providers and will continue as long as we have the Appendix K authority. We have also modified the service definition and limits allowed under the Appendix K so that services can flexibly be provided in various locations, including out of state if needed on an emergency basis. Life planning changes have also been made, so there is the allowance that services can start up, and then life plans can be modified. Following that, those provisions continue to be in place for all providers. The last item I just wanted to stress, because I think we've gotten a lot of questions from providers, so it's important for folks to realize. We will be talking about program day duration changes that apply to just some providers, but there are other changes that apply to everyone and are still in effect through the Appendix K. And that is when we talk about the billing standards and the program day duration requirements for rehabilitation and site-based pre-vocational service providers. That time includes time when staff are with the person in a face-to-face manner, time when staff are engaged with the person using remote telehealth delivery, and meal times. So all those provisions continue to be in effect and benefit all DayHab and pre-vocational services providers. So, what we want to focus on today is what is changing, and these changes are going to be in effect for certain rehabilitation providers. So it's important, I think, to understand sort of the history of the flexibilities that we've had under the Appendix K to understand what is changing now. So if folks remember back to the start of the pandemic, there was a period of time through July 21st, 2020, when we had retainer days, and day habilitation and pre-vocational service providers could bill retainer days through that date. Beginning on July 22nd and then sunsetting on October 14th, we had flexible billing standards for day hab and site-based pre-voc providers that allowed them to certain billing flexibilities if they were providers that had signed the attestation, so there was a signed attestation in place for that provider, and that they had agreed to certain billing parameters. For those providers, they could use those billing flexibilities through October 14th. What we're doing now with this action that we're going to be discussing today, it essentially goes back to October 15th, 2020, so this is retroactive, and it provides the continuation of the billing day flexibilities for certain targeted providers based on the community incidence of COVID or the incidence in a particular site if there are closures related to COVID. We anticipate that these flexibilities will remain in place and available to providers who qualify for the duration of the Appendix K. So in effect, what we've done is we've continued the provision that was in place through middle October. However, it is now targeted so that it really hopefully addresses particular needs in communities based on the variability that we have with folks experienced during the pandemic. I do want to point out, because we will not likely go into all the detail that surrounds some of that, the billing flexibilities that were in place through October, but at the bottom of the slide there is a link to the document and guidance that was published related to services and flexibilities through October 14, 2020. And we will also, as I said, be publishing a new Q&A for this particular change based on our discussion at today's webinar. So with that, I want to hand it over to Don Moffitt, who will be talking about some of the new flexibilities that are going to be retroactively effective.
Great, thanks, Kate. So just to note, the flexibilities we're talking about today, again, they're retroactive back to October 15, 2020. So who do the recently approved Appendix A flexibilities apply to? Well, the flexibilities apply to providers that have closed programming for any of the following reasons related to the COVID-19 public health emergency. The program is located in an area of the state with mandated closures. The program is closed under the direction of the local public health agency, or the program is not required to close but closes as a preemptive measure. So let's drill down a bit further into what these flexibilities mean for non-mandated closures. So for non-mandated closures, the program day duration modifications associated with non-mandatory closures may be in effect for a period of up to 14 days for risk mitigation. Longer duration of flexibilities beyond the 14 days are available only if there is a subsequent designation of the region as being subject to closure or another period of quarantine is determined to be necessary. Agencies must report the closure to OPWDD and demonstrate the need for the closure based on the Incident Reporting Management Application, or Irma, reporting of positive COVID-19 cases among individuals and staff at the affected sites. Okay, so let's now take a look at some of the billing standard flexibilities. So program day duration requirements are currently changed but consistent with the flexibilities that were in place from July 22nd through October 14th, 2020. In other words, payment for a full unit of service requires that the provider deliver and document a program day duration of at least 2 hours. Again, Likewise, payment for a half unit of service requires the provider deliver and document a program day duration of at least 1 hour. So just a note on what some of the program day duration includes. The program day duration does include face-to-face service time, time when staff are engaged with the person using remote telehealth delivery, and meal times. Just a quick note on perhaps what has not changed. The staff action requirements are not changed in terms of, service documentation. So for a full unit of service, providers must document at least 2 services had taken place. And for a half unit, the service documentation continues to require 1 service has taken place. And again, just to sort of restate before we move on, that these flexibilities are retroactive back to October 15th, 2020, and they are in fact a continuation of what was in effect from July of 2020 to October 14th of 2020. So with that being said, I'm now going to turn things over to Earl Jefferson from Central Operations, who's going to talk about claim submissions.
Thanks very much, Don. Good morning, everybody. I think here's where you'll see a little bit of familiarity with the prior period when we had these flexibilities in place. But the main thing to take from this is that we're using the revenue code of 0249 that will be the identifier on these claim submissions to indicate that services were rendered utilizing these flexibilities. This is the same revenue code that we had in place for the July 22nd to October 14th period. So essentially, this isn't a new thing that we're doing here. We're just going back to what we had in place for that prior period. The main point here is that this is the identifier that makes all of this work. So it's important that your claims include this revenue code, the 0249 revenue code, because down the road, if there's a post-payment review or an audit of the claims, and this is the revenue code, and this is going to be the indicator that's going to indicate that you're billing with these flexibilities. So I just want to stress that make sure you're using this, inputting it on your claims when you're taking advantage of these flexibilities, because this is the identifier that we have and that we're going to use. Obviously, both Kate and Don have talked about the retroactivity here. So certainly, since we're going back to October 15th, there may be claims that meet these flexibilities that you had billed prior as half-unit claims. Those claims can be adjusted in the instances where you meet these flexibilities. Because we're going back more than 90 days in some instances, those adjustments that need to be done in those cases, you will be able to use the delay code 15, which indicates the allowability of us to submit claim submissions that are impacted by the state of the emergency. So certainly if you go back, you meet the flexibilities that Kate and Don had talked about, and you have instances where you can adjust those claims, you certainly can do that. The main thing is, again, that you update the revenue code to indicate the flexibilities are being met. And then if you're running into situations where those claims are more than 90 days old, you can use delay reason code 15 on the claim submissions. Again, we used this before, so nothing new there. But again, the main thing to take from this is you have to make sure you're putting that revenue code on the claims to indicate allowing these flexibilities to be part of your submissions. Thank you. I think Aviva next. All right, let's turn it over to you, Aviva.
Great, Earl, thank you, and good morning, everyone. So I will be walking folks through the next couple of slides, which focus on service authorization. And as Earl noted, right before he covered the slides on claim submission, these next couple of slides should be familiar to folks as we've covered it previously. So I want to first talk about community habilitation in terms of service authorization. And obviously this applies to providers who have previously signed the day service retainer program attestation. So providers continue to have the flexibility to offer community hab to individuals who participated in day hab and pre-voke services prior to the public health emergency without needing to seek any additional authorizations from the DDROs nor do providers need to submit a DDP-1 or a DDP-1 supplement. Providers should continue to use the COVID-19 addendum to update the life plan and the staff action plan to reflect the addition of the community health services. The way that this works is that the provider initiates the update, sends it to the CTO care manager. The care manager signs and distributes the form to the individual, the service provider, and then emails a copy to OPWDD Central Operations. And as folks who previously used this are aware, we had included that email address on the form for folks as a reference. Next slide. In terms of service authorization for JHAB and pre-voc services, again, this only applies to providers that previously signed the Day Service Retainer Program attestation. So again, providers continue to have the flexibility to offer JHAB or pre-voc services to anyone who received any of these three, or as I refer to them, suite of services, DayHab, pre-voc, or ComHab, prior to the public health emergency. The one change is that going forward, effective March 15th, which is this coming Monday, any requests for changes to JHAB or pre-voc services to respond to an individual's needs during the public health emergency will require the use of a service authorization request form. And obviously, that would be submitted without the request for units. The care manager obviously would be contacted and would submit the service authorization request form, and there would need to be an update to the life plan as per the usual pre-COVID processes. Next slide. In terms of service authorization and financial limits, the monthly claiming for services authorized as part of the Day Service Retainer Program continue to be limited by the financial limits in the attestation. Any requests for permanent service changes not related to the COVID flexibilities would have to go through the normal process to secure services for an individual, again, requiring providers to contact care managers to submit the required forms. Associated claims are not subject to the financial limits in the attestation for those permanent service changes that are not related to the COVID flexibility. So Kate, I believe I will turn it over to you.
Sure, great, thank you. So as promised, it was a brief set of slides. What we do want to just point to here is that the resources on the OPWDD HCBS page continue to be available. You will receive an email when the recording of this session is available. And based on the discussion we will have today, we're also working on a question and answer document to document some of the responses to your questions that we will be receiving shortly, and make sure that we have some clear communication related to this retroactive change. I did want to point out also that there was a CMS letter that came out in December 2020. That's the Public Health Emergency Letter, and it stresses and talks about the ways that states should be working to reopen services. And I just wanted to put that there as a reminder to folks that while we're talking about the flexibilities related to COVID, we're very much focused on, as we move forward, how we resume services and, to the degree and extent possible, resume in-person services for folks. So while we're talking about the need for flexibilities, we continue to look forward, and there will be many more discussions happening as we all work jointly toward the resumption of normal. Hope and pray. So with that, we're just going to take a few-minute pause to go through your questions. If you have not done so already, please enter them into the box, and then we'll resume in just a few minutes to address any questions that have come in. Okay, we have a couple questions. One question is, if we closed a program because of a large number of cases during a particular month, but we were not in an area of the state that that had mandated program closures because of COVID, do these flexibilities pertain? So if you're looking backward, so you're going back into your service history here, and there was a period of time where you closed your program, but perhaps continued a remote service delivery or in-home services, via remote technology, but your site closed because of COVID, then that would be considered a non-mandatory closure. So you're going to follow the directions in the slide, and there will be additional information forthcoming. That's a non-mandated closure, and for up to 14 days, you can use the flexibilities for that period. So you would want to go back, and as Earl discussed, look at your claims for that period. And for anyone that you were able to serve remotely, but you only were able to claim, for example, a half unit, if your service support that, so you documented 2 staff actions and you had at least 2 hours of service delivery, in that instance you can adjust your claims to go back to the situation to update your claims as Earl discussed. Okay, we also had another question about the state's guidance on reopening and the limitations on, for example, transportation. I will say that everything is under review and guidance will be forthcoming. I think as situations in the state improve, and that's of course based on the experience in each region and each community, and also as the number of vaccinations continue to climb. So yes, we do anticipate that we will be revising guidance in conjunction with our sister agencies, but I don't have a time frame for that. Anything else that has come in that we may want to address?
There are a few questions for clarification on the SARF. So for those that now need a SARF for changes to the day hazard and PREVO programs, will a DDP-1 be required?
Abiba, could you hear that?
Thank you, Kate. Can you guys hear me?
Yep. Yes, thank you.
Great. Yep. If the change is being requested as a permanent change, yeah, a DDP-1 would be needed to ensure that that individual is enrolled into the provider's program. So this would be an individual requesting a change that's not related to the pandemic, seeking a permanent change. We would require that a DDP-1 be submitted.
And Abiba, if they're seeking to make a change that would, for example, someone was in pre-vocational services, they're able to deliver day habilitation, and it's not a permanent change, it's part of the flexibilities of the day service retainer program, would they also have to do a DDP-1 in that instance?
No, they wouldn't, because there would be an expectation that, when we begin to return to normal, that there would be a reconciliation of which services or supports that person wants to receive. So this would just be temporary, and a DDP-1 would not be needed for that.
Okay, so in that instance, the SARF form requesting 0 units would be sufficient?
Correct.
Perfect.
Okay, we had a couple of questions on revenue code. Is the revenue code 0249 used for day program, full day unit billing, if you were providing 4 hours of service and are counting the meal times as part of the 4 hours, or is it only needed when using the 2 hours?
It should be used only when you're not able to meet the normal, typical duration requirements. So if you're taking advantage of any of the flexibilities that Kate and everyone's talked about here today, you should be using the 0249 revenue code. If you do not have the 0249 revenue code, that means that you're meeting all the expectations that aren't coming into play based on the emergency waiver and what we're talking about here today.
So just to be clear, let's go back to slide 3 if we could. Is that something we can do? And Earl, correct me if I'm wrong, but if we look at slide 3,
could you just read the title?
It's Appendix K, Flexibilities, the chart.
Oh, the chart.
So if you look at the Appendix K flexibilities, this is the chart that applies to all providers. And so, for example, if you are delivering 4 hours of service for your, let's take an example, your day habilitation program, if you are using face-to-face service time, if you are using remote technology, if you are counting meal times toward that, you would not need to use the special codes, okay, because those provisions apply to everyone. Where you need to use the special codes is where you are modifying the program day duration requirements of 4 hours and 2 hours. And Earl agrees with me, so we're good.
Sounds great.
Another question regarding the 0249 code. Do we have to do a void adjust for previously billed claims and then use code 0249 to rebill the claim based on recent regulations?
You could do that. Normally we would advise against that, and I would really advise against it. Doing an adjustment would be an easier thing to do, but because we have the delay code 15 in place for the emergency period, you could void your claim and rebill an original claim. Typically, we always suggest providers do adjustments rather than voids because normally we run into timely billing rules and timely billing circumstances. So here you could do that. I would still suggest that you do an adjustment of the claim instead, but that is a possibility that you could do that because we have the flexibility of the delay code 15 in place for the duration of the pandemic.
Okay. Can we also do an adjustment to previously non-billable services to a half day if needed?
If they're non-billable services, that means you haven't billed them, so there wouldn't be anything that you could adjust from a claim perspective. If you didn't bill something going back to October 15th and it meets the flexibility, you could submit that now and you could use the delay code and it would pay as an original new claim, but you wouldn't be able to adjust anything that hadn't been submitted already and processed and adjudicated as a paid claim.
Okay, and does the billing flexibility apply to programs which were open but could not serve individuals in person due to capacity limitations?
No, so I think we need to make a distinction here. If there is not a formal closure of a program or a service, then that would not meet the standards for the flexible billing standard. You continue to be able to use meal times, you continue to be able to use remote technology, but you can't, have a 2-hour program day duration and qualify for a full unit.
Okay, regarding meal times and telehealth, are these contingent upon program closing, or is that overall any day have service?
No, and I'm glad the question came up again because it's really important that folks are able to distinguish this. When you look at slide 3, those are the flexibilities that are offered through the Appendix K for all day have and pre-vote providers. So the mealtime allowance, the use of technology to deliver remote services, those both continue for all providers throughout the duration of the emergency until we end the Appendix K authority.
Okay, there's also a question about the non-mandatory closures based on Irma. If there was significant community spread but no specific cases at a day program and the agency closed the program to ensure individuals and staff were safe, would this be considered eligible?
Sure. So if there was an action by the provider, it's a great question. There was an action by the provider to close a program, again, non-mandatory, so limited to 14 days. The provider can take advantage of this flexibility. In this instance, what the questioner brought up is that they weren't necessarily cases associated within the program. Therefore, you wouldn't have Irma reporting. But you would be able, I would strongly recommend that providers maintain in the record, the notice of the closure that you sent to participants so that if there were any questions about, post-audit reviews, for example, you would have that in your record to document your use of the flexibility.
Okay. What are the rules for day services provided to residents of ICF?
We do not have flexibility through the Appendix K for day services in the ICF. That is really a state plan service. I think that's something we're going to have to take back and we'll address in the Q&A. But it's a great question, and we will certainly include it in the Q&A.
Okay. If an individual prior to COVID received ComHab and DayHab, but is now only receiving DayHab in the IRA, can the number of days be increased without a SART, and does the life plan have to be updated within 60 days?
So I believe what we're saying is the person, let's take an example, prior to COVID participated 3 days a week. They are now participating in DayHab services within the home 5 days a week. You do not necessarily need to update the record, but you are limited to, again, because it's part of the flexibility, you're limited to that prior claiming period. So you do have flexibility to provide that person with 5 days of service, but you have to be mindful of your overall utilization for that period associated with the attestation. And Abiba, would you agree with that response?
I would, Kate.
Great, thank you.
Okay, we have a question about if a day facility has been opened and closed multiple times in the period, are you limited to 14 days across all closure periods?
No, if there are unique occurrences, like let's take an example. November you closed for 14 days because of high incidence. You can use those flexibilities for November. You reopen, and then a month later you have to close again because of high instances. You can qualify for multiple days. What becomes problematic, obviously, is stringing along lots of 14-day periods. That's really not appropriate. But individual events certainly can use those flexibilities.
Okay. For a non-mandatory closure with full remote and distance learning model in place for all, can this continue? How do we proceed with families who are extremely reluctant to sending their loved ones back to programs?
So if you're in a non-mandated closure area, you can use the billing flexibilities and deliver services remotely, again, limited to that 14-day period. You can, other than if you're going to not use those flexibilities, you can obviously continue with remote services for the duration of the pandemic, obviously based on folks' needs. I think it's really a challenge for all of us. I mean, as hard as it was to close services, reopening in many ways is going to be even more challenging, I think. It's something we're all going to be working toward together. And hopefully as more and more people become vaccinated and we have better results, and things continue to improve, people will be more and more confident about returning.
Okay. Does this apply to DayHab without walls?
Yes, that's a very good question. So the flexibility that we're talking about here, just like the prior program, applies to DayHab sites and DayHab without walls. So, for example, if you had a DayHab Without Walls program and it was in person and you sort of closed that operation, you would qualify for this flexibility for up to 14 days in a non-mandated site, or you would follow the mandated rules if you were in that area of the state.
Okay, another question about financial limitations. If they are not met by the provider, the DayHab duration flexibilities cannot be used, correct? Could you go over what the financial limitations are again?
Sure. So for providers that signed an attestation, and that was done over the, June, July, for providers that signed that attestation, they also received a report that was the average claiming for the three services, DayHab, pre-vocational services, and community rehabilitation, for the period of July 1, 2019 through December 31, 2019. So if your provider agency, without these flexibilities, and you are able to bill over that amount, then you would not qualify to use these because you've passed that bar in terms of financial resources.
Okay, do the Appendix K flexibilities apply to community-based pre-vote programs?
The flexibilities that we're talking about here in terms of 4 and 2 hours do not, because it's based on a full unit and a half unit claiming. Community pre-vocational services like Community Hab is 15-minute units, so there's no modification to those units. Community rehabilitation, community-based pre-vocational services can use the flexibility of telehealth, meal times, et cetera.
Okay, there's a few questions on evidencing the program closure. Are providers just expected to retain the notice of closure?
I would recommend that. I mean, it's part of your Medicaid record, so I would retain it with your other records, not necessarily in a person's own individual record, but certainly you would want to, if you're going to use those flexibilities, you would want someone in your claims office, your business office, to be retaining whatever evidence you have that would meet those standards.
Do all of these flexibilities still expire on 3/31/21?
Great question. And I'm going to go out on a limb here and say absolutely not. So we do have our Appendix K approved through 3/31. We do have a request into CMS to extend this Appendix K with these provisions that we're discussing today through 6 months past the end of the pandemic, so for quite some time to come. I have absolutely no doubt whatsoever that we will be approved. That is a flexibility that is offered to all states. It's just a matter of, when the process is complete. So it does not end on March 31st, and people should be confident that for the duration of the pandemic, we will certainly have these flexibilities.
Okay, there's a question on partial closures. Would those be eligible? For an example, if there were 2 cohorts quarantined, but the rest of the program remains open, can you speak to the requirements about that?
Sure. So, let's take an example. You could have a provider that has 2 sites or has 1 big site, and there's various cohorts. It would apply, the flexibility would apply to the cohorts that close.
Okay. What if we close the program but continue to provide some services in residential homes and on Zoom, but the site was closed?
Yeah, so the issue is, and again, it could be site, it could be without walls. If you closed the site, we encourage you to continue to provide services to the extent you can, but you had to close the in-person service delivery. You would qualify for that modified billing standard for those services that are delivered, for example, in an IRA, or for those services that you can deliver via remote to a person's home.
Great, thank you. Can we bill a day full and day half for, can we bill a full day and a half for a visit before 3 p.m.?
I think what we said before was you can't use any of these flexibilities when you have more than a full unit of service, I think, Kate?
Yeah. So you can't take, a 2-hour service, call it a full unit, and then bill another half unit. So, no.
Okay.
And that's some of the rules that that link that is on slide 2, I believe, details the answers to that kind of question, because that was part of the prior period. And that was on slide, I lied, it wasn't 2, 4. On slide 4. But again, we'll go back out with a Q&A that's more up to date, and we'll address that there as well.
Okay, we have a couple more questions. Request for clarification on the telehealth 6 months past the pandemic, and we speak a little bit more to that.
So there's a group of flexibilities in the Appendix K that continue to operate in addition to those we've discussed here. That includes very broad use and ability to use telehealth during the I'm trying to think. We haven't talked about community-based pre-vote. Community-based pre-vote can certainly use telehealth, as can supported employment. All those provisions will last as long as we have Appendix K authority. We are requesting and anticipate that we will have Appendix K authority past the end of the pandemic. That's what we have requested against CMS. In the best case scenario, things go super well, everybody's vaccinated, everybody's fine, and we can end the authority even earlier because we just don't need it any longer. That's my hope, but for the time being, as we are working toward reopening, the Appendix K flexibilities continue to be in place for providers, including telehealth.
Okay, great. What if we closed, apologies, 1 second. I'm in technical difficulties here. Okay. Can we do 2-hour full units billing for the work we are doing in Zoom and in the IRA?
So if you qualify for the flexible billing standard, so a full unit for 2 hours of service delivery, first of all, you have to qualify for that. If you qualify for that, any services that you deliver for people associated with that program, whether it is in the residence or whether it is, the person, you're the Zoom calling to the person in their own home, then yes, you can use those flexibilities.
Okay. For planning purposes, are we able to move ahead with the plan that Appendix K will be approved to go beyond 3/31/21, or do we need to wait for approval?
Go ahead.
Okay. What if we close building sites due to low census and combined with another location?
So that is not, if your census is now sort of permanently lower and you're making those kinds of shifts, those are changes that you're making. You'd obviously work with the DVRO and make sure everyone is aware of those changes, but that would not in and of itself qualify for the use of these flexibilities.
Okay, so if a program has opened with limited space, so some people are getting remote service, do they qualify for 0249 billing?
Wait, can you repeat that?
If a program has opened with limited space, so some people are getting remote services, do they qualify for 0249 billing?
I don't think so,
No.
because they don't meet any of the flexibility requirements.
Right. So, just to be clear, if you're making operational changes about restarting, and you have some people coming in, Monday, Wednesday, Fridays, other coming in Tuesday, Thursday, and you're doing that to, keep cohorts where they are, or, to limit the potential spread of COVID, that does not in and of itself qualify you for these flexibilities. It has to be an actual closure of services because of COVID in the non-mandatory areas or in the mandated areas. You basically qualify because of the status of the community.
Along the billing lines, is there any news about the billing cap and how that will be handled or reconciled?
We've started to have some discussions with the Department of Health, but we don't have anything to report just yet, but we do expect to be initiating some discussions on that soon.
Okay. Does the billing flexibility apply to programs that were allowed a maximum return of 15 people?
Again, what we're talking about here is not sort of your, again, I'm going to focus it on in non-mandatory areas. So if you're in a mandated area, you're in a mandated area, and we're done. If you're in a non-mandated area of the state, this flexibility is allowed when you have closures related to incidents in your program or in the community. So it wouldn't be that you are permanently opened at a census of, whatever that is, and then perhaps serving other people remotely.
Okay. Please clarify if providers need to do another addendum for CHR services.
No, there's no need to do another addendum for Community Hab R. There's an addendum that was developed just to remind everyone to facilitate Community Hab R for individuals who live in a residence and cannot participate in day services. That same addenda was used to provide flexibility to deliver Community Hab to people who could not participate in day hab or pre-book because of COVID. And that does not need to be updated. That continues to be functional until such time as we need to begin to consider people's permanent service needs.
Okay. Should BPC be notified as well as the DDRO if the changes in capacity are occurring as day habs merge due to dwindling numbers?
I don't know, Abiba, did you hear that?
Yeah, if it's going to be a permanent change, absolutely.
Okay, great. Thanks, Abiba. So there really is no relief for day programs that are at reduced capacity right now due to COVID spacing restrictions. Is that my understanding correct? This relief is really about program closures. So if you have not closed a program because of COVID and you have not done so retroactive to October, then you continue to have the flexibilities to, for example, to do telehealth, to count lunch. Those exist for everyone, but you don't meet that threshold of closure. I will say I'm sure you're all following the federal bill. There are other actions that will be forthcoming, but this one is limited to, in non-mandated regions, program closures or partial closures. Okay. There's some confusion over the life plan paragraph in the PowerPoint. It states the life plan must be updated as soon as possible, but not later than 60 days. But then says the corresponding staff action plan must also be updated. The timelines have been waived until 60 days following the cessation of the public emergency.
Right. So we created the addenda process, and this may be the source of the confusion. And the addenda process basically combined the SARF, the staff action plan and the addition to the life plan, and those do not need to be updated. But for example, during the pandemic, this is just a reminder that there may be other changes that are being made that would require a life plan change, and in those instances, we have the flexibility to take some more time to make those changes occur in the life plan.
Okay, I think the last couple of questions are related to whether or not the PowerPoint is going to be distributed.
So the PowerPoint will be available on our website along with the recording. It's going to take us probably a couple days typically to get that published, but it will be available. And we're also working on a Q&A document that we want to get turned around as quickly as we can to assist folks. So we will also have that available, and we will inform people when that's up.
We do have time for a couple of questions that just came in. They would like confirmation. Program is closed. Non-mandatory telehealth has been provided the entire time for all individuals. Under the Appendix K, we are providing full-day telehealth. Please confirm that this is allowed to continue past the 14 days as it is our current mode.
So if you are able to deliver 4 hours of telehealth, then you don't need the flexibility because you've met the standard. So absolutely, if you can do that, continue to do it. That is absolutely allowable.
Okay. Do you anticipate the ability to provide day hab within an IRA to continue past the pandemic ending 6 months after the pandemic ends?
So we're very closely looking at those types of provisions where, for example, it would be clinically appropriate to serve someone in a residence. So it's something we're definitely looking at, And I think we're very intent on having some definitions and guardrails around when that's appropriate and when it would not be considered appropriate. And I would want to remind everyone that HCBS settings rules really require that people are not isolated from the community. And one very, high bar that we would need to know is that where that service is going to continue after the pandemic, that someone is not isolated and that we're in full compliance with HCBS standards. And I don't know, Aviva, do you have anything else you want to add to that?
No, Kate, I think you captured the critical points on that.
Great, thank you. Okay, we'll take one last one, and then I think we'll call it.
Okay. Can we continue to provide ComHab to people that have the COVID addendum after 3/31/21?
Yes, you can.
There you go.
Yes, you can continue to use that addendum, and we are really thinking very intently about exactly what the process of sort of, reopening is the term we'll use. But we're giving that a lot of thought, and there will be more to come on it. But yes, absolutely. If you're delivering community HAB-R to someone using the flexibility of the addenda, that will continue after March 31st. So with that, I want to thank everybody for your time. I very much appreciate it. Some great questions today, so I really do. I thank you all for your participation. We will be taking those questions in and hopefully getting back to you very quickly with responses to your questions. I would encourage people, if you have questions, there's the OPWDD People First website that you can always send your questions into. But if it's related to this particular webinar, let's wait until we're able to assess the Q&A before we respond through that venue. But I do want to thank everyone and thank everybody for everything you've done during the pandemic to serve the people who we're responsible to provide services to. We really appreciate everything that folks have done over the last, can you believe it, 1 year. All right, thank you, everyone. Have a great weekend.